Thank you. Thanks, like everyone else has been giving thanks to NTMIR. Also, I'd like to thank UCSD, Weil in particular. Also the sponsors, our industry sponsors, for making this possible today. I got the very easy title, What Else Is There? Adjunctive Therapies. I struggled with this a little bit. First, just my conflicts. So I went to the dictionary. What the hell is an adjunct? So it turns out it can be a noun or an adjective. If it's a noun, it's a thing that's added to something else as a supplementary rather than an essential part, such as computer technology is an adjunct to learning. As an adjective, it's something that's connected to or added to something. This is a real definition, by the way, typically in an auxiliary way. Now, this really fits in with today's talk, and adjunct therapies include immunotherapy, because I'm actually going to talk about that. So this is an adjunct. So when I started thinking about what are some of the adjuncts, one we just heard, psychosocial support, I think is a very important adjunct to the treatment of our patients with NTM. So I thought about what are some of the others. Airway clearance. Well, we've heard a little bit about that, and we're going to hear more in a few minutes, so I'm not going to discuss that. But I think that is not an adjunct. I would argue it's essential for the treatment of our patients with NTM who have bronchiectasis. Treatment of comorbidities. We've heard about bronchiectasis. We're going to hear about cystic fibrosis, and it's critical to maximize or optimize the therapy of the comorbidities. One that wasn't mentioned that I will discuss that I think is very common is, guess what? Gerd. Some of you are probably having a little bit after lunch, so we're going to talk about that. Nutritional support. Also, I would argue that perhaps this isn't an adjunct. Perhaps this is really more of an essential part of the treatment of our patients. As I mentioned, immunotherapy, and something I was specifically asked to address, which is surgical resection. So I'm going to start at the top, and we're going to go down, except we'll skip the airway clearance because that will be discussed. So Gerd, I love this cartoon. I can't sleep. I have indigestion from eating all them fire ants before bed. You better take antacid. So this is what we do, right? We hide it. And even if you don't feel the burn, that doesn't mean you're not having reflux. The reflux is still happening no matter how many antacids or proton pump inhibitors you take. And that's a critical part of addressing the management of this. So what is Gerd? Well, a healthy individual has a sphincter at the esophagogastric junction, which is tight. And so after we eat, it is tight, so the liquid that we eat and the food that we eat is basically it stays in the stomach, and it cannot back up into our esophagus. Because once it gets to our esophagus, it has almost, unrestricted flow, potentially, to our lungs. Now, in the setting of Gerd, there's something wrong with that sphincter, and it leaks. And so whatever you eat can back up. So this is what we call Gerd. But there's something I want to mention, is there's something that's not Gerd, but maybe just as common and just as important, and that's esophageal reflux. So it's not that it even makes it to your stomach and backs out, it sits in your esophagus. Why? Because you have a weak esophagus. So part of the workup, we focus on Gerd, and I'm going to speak about it, but there's this other entity in which people's esophagus is weak, and the food never makes it all the way down. And I'll show you an example of that in just a moment. So Gerd, it turns out, is very common. 10 to 20% of the Western population has symptomatic Gerd. Interestingly, it's less than 5% in Asia. And asymptomatic Gerd has been shown to be very common in people with other lung diseases like asthma, pulmonary fibrosis. A couple of studies have reported 62% of asthmatic patients will have asymptomatic Gerd, and 75% of people with idiopathic pulmonary fibrosis. And in both of these conditions, that Gerd is associated with worse outcomes. So it's important. The diagnosis is often based on that trial, that taking an antacid when we feel the heartburn. But if this many people don't have heartburn, then that's obviously not going to work. And it turns out for people who are managing themselves by just treating the heartburn, they're not recognizing that the reflux is still happening. Now, the best diagnostic test for detecting this is for acid reflux and non-acid reflux is a 24-hour esophageal impedance test. This is an example. This is a tube that goes into your nose, into the esophagus, and it stays for 24 hours. If you want it only to be in for 22 hours, come to National Jewish because we do it for 22 hours. And most of our patients don't look quite like this when it's in there. They're not smiling. It's not a comfortable test, but it is the Cadillac test in terms of determining how frequently you have reflux, whether it's acid or non-acid, and how high up it goes. So there's tremendous amount of information, and it's not uncommon in asymptomatic disease that people have severe reflux. Now, this association with esophageal disorders in NTM is fairly old, almost 40 plus years ago. Mycobacterium fortuitum was described in a patient with achalasia in 1970. Most of the reports that have followed have associated esophageal disorders with the rapidly growing mycobacteria like fortuitum, but also Mycobacterium abscessus. This is a report from last year, so this is something that still is being reported on. Let's see if I can get the... So what you see here is the esophagus, giant. Normally you can't see the esophagus or you can barely see it. This is someone who has that condition reported in 1970 in the patient with fortuitum, which is a very dilated immotile. So this is an extreme, but you can see inside there, it's not black filled with air, it's filled with food. So these extreme examples sometimes give us an idea what could be happening, that if food is not passaging, it could be refluxed and subsequently aspirated. So that's kind of the beginning of this association. Now, this is a study from Australia, Rachel Thompson, who will be coming to ATS. This was a case-control study, so she had 58 patients with MAC, so not the rapid growers. So this is to demonstrate it also occurs with the slow growers like MAC. And she had 58 patients with lung disease without MAC. They were given a clinical, basically, survey that tries to get an idea of whether they have symptomatic Gerd. So this didn't do testing as part of it. 44% of the patients with MAC had Gerd versus 27.6 with who were their controls, and that was significant. So it says symptomatic Gerd among MAC patients in Australia was very common. They also tried to assess, again, through a historical process of taking, of assessing whether they thought, as physicians, the patient may be aspirating. And that was also more common in the people with MAC than control. So in this early study, 2007, it was a common finding to see symptomatic disease and more common in MAC patients than control. Wenjin Ko, who is here today, 58 patients. Now, figure this out. How many were in the other study? 58 patients. I don't know, what did you guys get together and decide 58 patients is going to be it? But this, I think, is the best study that has been done. It's not a large study, but instead of taking just a history, they did use an impedance pH probe. They had 27 patients with MAC and 31 with abscessus. They did the ambulatory testing, and again, they found the prevalence of Gerd was 26%, so a quarter of their patients had Gerd, but only 27% had symptoms. They're using one of the Cadillac tests, and the people didn't know they had it. And very importantly, Gerd was associated with more extensive disease. They were more likely to be smear positive and more likely to have more extensive radiographic involvement. So Gerd, I believe, is an important issue that we need to address in our patients. First, we have to look for it, and then we address it. Now, treatment is lifestyle modifications primarily, because as I said, you can neutralize all the acid you want, but it doesn't stop the reflux. The reflux still occurs. That's why the lifestyle modifications are important, like elevation of the head of the bed, not eating 2 to 3 hours before bed, avoidance of trigger foods, if you know what those are. But it turns out, in 16 studies that have looked at this, the only things that have been significantly associated with improvement in either the pH probe or symptoms are elevation of the head of the bed and weight loss. So I tell everyone who I find has Gerd that they should lose weight and that they should raise the head of the bed. Antacid treatment, yes, for symptomatic patients or those who have what's called erosive esophagitis, and that's only noted by doing an endoscopy. And for the more severe forms, surgery may be required. So Gerd is something for us to consider. How about nutrition? I love this. Let's eat grandma. Let's eat grandma. You know, apostrophes are important. So punctuation saves lives. If there's nothing else I teach you today, that's probably the most important. So why is nourishment important? So undernutrition has been shown, mostly in studies of children, but for many, many years, to result in some bad things like low protein levels. These do affect our cell structure, our immune response, metabolic functions, calories, most of which we get from what are called macronutrients like proteins, carbohydrates, and fat, and deficiencies of micronutrients, one of which I'll speak about is vitamin D, but actually all of these have been studied in some disease somewhere. The reason this is an important issue is there's actually a vicious cycle that occurs when we become sick. Particularly the sicker we become, we will lose weight. And why do we lose weight? Well, for one, we lose our appetite. When we're sick, we don't want to eat. That reduces our food intake. Also, when we get sick, we often don't absorb our nutrients as well. This basically then makes us undernourished, and that affects our immune system. And on this slide, there are multiple ways. We won't go into the details, but there are multiple ways. Both humoral immunity, cell-mediated immunity are affected by undernutrition. And so when that happens, we get more infections, and a vicious cycle occurs. And this we see in our patients all the time. In the patients here, this is what you experience. Multiple infections that can occur over time. What about in the setting of NTM? This is a recent study that was a systematic review, so it looked at all the world's literature, and these are all the studies that they found that looked at a 5-year mortality in patients with pulmonary MAC. And for those of you not used to, these are called forest plots. I'll come back, well, I'll leave that. What you see here are the percentage of the percentage 5-year mortality, and if you add it all up, 27% 5-year mortality in patients with pulmonary MAC. That is a substantial mortality. If you look at how much of that they thought was related to the MAC, and there's some judgment here, it was 5 to 42%. Still quite substantial risk of 5-year mortality in the patients that were studied. Now the patients that were studied here varied a lot, from mild disease to very severe disease, hence the very broad range of mortality. But if you look at the statistical associations with mortality, you can see the ones that showed up the most were older age, male gender, comorbidities, cavitary disease, high inflammatory indices, things like high CRP values, high SED rates. But what I bolded is nutrition, markers of nutrition. A low body mass index, and we've actually seen that mentioned a couple of times today in previous talks, and low albumin, which is a serum protein that goes down with malnutrition. So it's a form of protein nutrition. The low body mass index is a form of caloric undernutrition. So nutrition matters. It affects mortality. It affects quality of life. Now, one of the ones that we look at all the time that I listed as a micronutrient is vitamin D. So the first most important thing you should know about vitamin D, it's not a vitamin. It's actually a hormone. It's a steroid hormone. It's not a vitamin because vitamins are something we don't make in our body, but we do make vitamin D in our body, therefore it is not a vitamin. We all know how important it is for our bone health. That's one reason we check it, particularly in women. But it also has a critical role in our what's called the innate immunity. And through various mechanisms, it actually is a bridge to the next form of immunity, which is called adaptive immunity. That's when our cells have time to recognize the antigens and attack them. There have been multiple studies that have looked at the importance of vitamin D levels in tuberculosis. Both do you have a higher risk of developing TB based on your vitamin D level, or are you more likely to respond to therapy? And the results are very mixed. And just to remind you, how do we get vitamin D? Well, we get it from the sun, but no dermatologist will allow me to tell you to go out and get sun. So we ingest it. And, you know, that's the main place in the world today, outside of people who are working outside all the time. That's where we get our vitamin D, is from ingesting it. So it's converted in our skin to one form of vitamin D, vitamin D3. The liver actually hydrolyzes that and produces another form. And then the kidneys take that and change that into what's called 125 hydroxy. And that's actually biologically active. So it goes through a process. But again, most of what where you're going to get your vitamin D is from what you eat. Does it matter? Well, I mentioned Dr. Ko. I'm going to mention him again. This is his group who are here today. This is looking at prevalence of vitamin D deficiency in a case control study. He looked at 104 pulmonary NTM patients, 312 controls. So what you see here is the patients that are spread out over how severe their level, how low the levels were. To a normal level, sorry, very touchy screen here, all the way down to what he called severe low levels. And it was only in that group did they find an association, but a statistically significant association with NTM. So if they had a severe deficiency of vitamin D, less than 10, which is quite low, they were about 4 times as likely to have NTM. As we went higher in the level, though, we don't see much. So it looks like, at least from this one study that has looked at this, that it requires severe deficiency of vitamin D to really see this association. But it's a small study. A much larger study would need to be done. So if we go back to our goals, protein. What we're trying to do with our patients is to normalize their prealbumin, which is a precursor of the albumin, and get the albumin up to as close to normal or in the normal range as we can possibly do with changes in their diet. Calorically, we want to see weight gain. Every time you come to clinic, we're going to weigh you because we want to see you gaining weight, and we want you to be as close to your ideal body weight as possible. And micronutrients, we check vitamin D in all our patients. I've shown one study that showed perhaps association with severe deficiency, and we're aiming to get into the current U.S. standard of 30 to 100. I do think an MBI, a multivitamin, is not a bad idea, but don't go crazy. I mean, I don't want to see you coming out of one of these health food stores with an entire tray full of supplements. There are no data to support any supplement on earth for the treatment of NTM. I wish there were, but there aren't. There just are not randomized placebo-controlled studies. So we're left with really not knowing if those work. So we try to get you into these normal categories. I think the other thing that's important is if you're below your body mass index and you cannot on your own get it up, you need to consult with a dietitian, a nutritionist to help you do that, because I think it's a very important component and adjunct. Okay, let's talk about host-directed therapy or immunotherapy. This has been a very frustrating area because this really exemplifies the science. If you put an elephant in the room and you put a bunch of scientists around the elephant and you blindfold them, give them a tool and go to say, what is it in the room? They're going to tell you something else. They don't all see the same thing. And right now, our immune system is extremely complicated. This is just kind of a very simple slide showing that there are multiple steps in response, in this case, to tuberculosis, that we don't quite understand. And we don't understand it as well with non-tuberculous mycobacteria as we do with TB. So it's a very complex area, and various scientists think this is more important than this one. The T cells are more important than B cells, and so forth. But I think this is a very important area that needs more research. Now, there have been studies in the NTM population, but they've been disappointing. The first one was a British Thoracic Society sponsored study that was a randomized controlled trial, so a very high level of design, in people who had pulmonary NTM, including MAC, and they got vaccinated with another mycobacteria, Mycobacterium vaccae. Unfortunately, in this trial, it showed no difference in outcome when compared to the placebo, so that pretty much died as a field, as an area of investigation. Interimune, a company from the Bay Area, a number of years ago sponsored a randomized, again, controlled trial of inhaled gamma interferon in patients with MAC, with pulmonary MAC. No difference was seen when compared with placebo, and it was actually terminated early because of that. This was a positive trial. This was from Cuba. This was a randomized controlled trial, also of gamma interferon, in predominantly MAC patients. They used a composite score, meaning they looked at multiple things to say whether or not they thought the patient was better. This can be very confusing to analyze. They used symptom improvement, radiology improvement, microbiology improvement, and came up with one score. And using that one score, they showed that there was more improvement, 72%, in those who got inhaled interferon versus those who didn't, and that was significant. So there is one positive study suggesting there could be a signal there. Part of the problem is we don't know what dose to give. We don't know how frequently to give these kind of things, these immunotherapies. But it suggests there's a possibility. More recently, something important to one of our sponsors today, AIT, is nitric oxide. Nitric oxide has multiple ways that it affects our body, and there are multiple ways that it affects our immune system. Nitric oxide is actually a gas. It's in very, very low concentrations inside our cells that kills organisms. It's an essential part of that innate, that early immune response to an organism. And in the setting of inflammatory or infectious conditions, it actually goes up inside our cells. And this can be measured in various models, including animal models. And it has potent antimicrobial effects, not just against mycobacteria, but that is one organism in which this has been studied. The problem, of course, there's always a risk, and it turns out nitric oxide, if you give too much of it, it makes our hemoglobin molecules change into something called methemoglobin. And for the patients who may not be familiar with this term, when that happens, then the hemoglobin can't bind oxygen, and that's not good. If your hemoglobin can't bind oxygen, then it can't deliver it to your tissue. So that is what has to be, this is one of the things that has to be looked at. Now, these are data that have been presented by many here, but I think are very intriguing and what are driving the interest in inhaled NO. This is inhaled NO for M. abscessus. This was a compassionate use. The patients were given intermittent treatments for 30 minutes at 160 parts per million for 3 to 5 times a day over about 3 weeks. This was added to failing regimens. So 2 patients. The first was a 19-year-old who had progressive abscessus for 7 years. Which is not that uncommon, but failed treatment, and his FEV1, so a measure of the lung function, was declining significantly. So there was some urgency to find something to work. What you see here is that the patients, let me get up to here, and the first graph shows is that on the y-axis, that we're looking at a measure of the bacteriologic load, not a culture, but a molecular method. And after starting therapy, you can see that it dropped. Now, it didn't go and it didn't stay negative, but there was a really significant drop. Ultimately, the patient felt better. Their FEV1 increased a little bit, not much. No adverse reactions, and the methemoglobinemia, which they were looking for, stayed at around 4.5%, so the patient's oxygen levels were okay. In the next patient, even more dramatic, a 13-year-old with progressive M. abscessus, both of these are CF patients, who had failed therapy, also had a significant decline in lung function. And what we saw here was they became culture negative, and they stayed culture negative for 2 years. Abscessus, Mycobacterium abscessus, with this short-term treatment of NO. The patient also felt better. FEV1 did not change much. So we're not seeing a change in the FEV1, at least in a relatively short time. But again, no adverse reaction. So 2 examples, anecdotes. Now, there are more data. There are studies that are ongoing that are going to look at this in a more rigorous fashion with more patients, but it just shows you that there may be a role for immunotherapy in the treatment of our NTM patients. And the final issue regarding immunotherapy is the macrophage. The macrophage is one of the first lines of defense. It's a very important cell that lives in our lung. And we know from various studies that the macrophage in CF patients doesn't work well. For various reasons in the setting of inflammation, the macrophage doesn't work as well, and that, of course, could lead to the inability to control infections. Now, there's this molecule. This is called granulocyte macrophage colony stimulating factor. It's a long name, so we call it GM-CSF for short. And it turns out the alveolar macrophages, when this molecule has been looked at in mice who cannot produce this, that it does affect their immune system. Dr. de Groot, Marianne de Groot, has shown in a knockout model, which means that the mouse cannot make this molecule, that the mice are more susceptible to M. abscessus. So the point of this is they're showing that it's important in fighting M. abscessus. So what if you give somebody? Give it back to them. That has been done. This is the case. It was a 10-year-old with cystic fibrosis who had a 3.5-year history of Mycobacterium abscessus. This was given aerosolized, 250 micrograms twice a day, in addition to antibiotics, and it was given on alternative weeks. What we see here are the culture status on the y-axis, so their smear status, which is in the white boxes, and their culture status in the black boxes. And if I can do this without making this move, GM-CSF was started here, and the cultures became negative very soon thereafter. But we don't have a long follow-up in these patients. So early response looks pretty impressive. This one, I think, even more so. This was a 25-year-old with cystic fibrosis with 13-year history of M. abscessus. And we see the same thing on the y-axis. We see their culture status and their smear status. And then look what happens right after they start the GM-CSF at the end of the curve. They very quickly go to culture negative. Now, whether they're going to stay, I don't know, and how long do you have to treat people. But these are two examples that there may be a role for immunotherapy, stimulating the immune system to be better, and thus, maybe they're not always going to be considered adjuncts. So let me end with surgery. So this is what we envision. This is kind of how we envision when we go to surgery. But at National Jewish, it's done differently, because standing at the end of that table is Dr. John Mitchell. And how could you not feel good when you woke up and saw John Mitchell sitting there? He is the surgeon that works with us. Other centers have also excellent surgeons. Dr. Mitchell's probably the most experienced. He operates on around 80 patients a year who have mycobacterial infection. The key here is not only having a good surgeon, but it's also how do you decide who should go to surgery? So we need to think about the indications and the contraindications. I think most of us would agree on the indications are if you have resistant organisms like macrolide-resistant MAC, Mycobacterium subspecies abscessus, or other difficult to treat NTM, that would be someone to consider, particularly if they're failing therapy. Treatment failures of any kind are someone we would consider. People who have focal pulmonary disease like cavitary disease or just one or two places in which there's severe bronchiectasis, and if there's a complication like coughing up blood. We take pause in moving forward if they have poor lung function, if they have pulmonary hypertension, so high pressure in the right side of the heart. If they're malnourished, we won't do it. We will send them out with a plan to gain weight and normalize their proteins and then reconsider, or if they have other serious comorbidities. But I want to take issue here with this term focal pulmonary disease. So what does that mean to someone when I say focal pulmonary disease? These are three patients. The one at the top has a large cavity in the right middle lobe. The rest of the lungs look pretty good, not perfect, but pretty good. So we would all say, that looks pretty focal. If that person's failing therapy, if they have macrolide-resistant disease, that's someone that would make sense to go in and remove that lobe. The one below that has two small areas of bronchiectasis. Again, if I could get over there. Here in the lingula, oops. And on the other side in the right middle lobe, well, those are focal. They just happen to be on two different sides of the body, but they're still focal. Most of the other lung and the rest of the lung looks pretty good. And then at the bottom is someone whose entire left lung is gone. It's been totally destroyed by Mycobacterium avium complex. So you would look and you would say, which one of those do you think should go to surgery? Well, they all went to surgery, and they all did well, but they were highly selected. The next example, these two are two slices of a CT from the same person. So we see a big cavity in the right lower lobe, and then on the other side we see again a little bit of atelectasis and volume loss in the lingula. Then on the other side they have right middle lobe disease. So this person, believe it or not, went to surgery. All of this was taken, and they were cured. They're still cured. The next patient, basically his right lung was destroyed. All the big black areas here are holes. Those are giant cavities. But the left lung was really good. So this patient had a pneumonectomy. The whole lung was removed. She was cured 10 years ago. So these are times where we have to think outside the box, but you do it being very careful, good surgeon, and go through the process of looking for indications and contraindications. Now, what's pushed us to be more comfortable doing this is really the advent of video-assisted thoracoscopic surgery, or VATS. This is where two small incisions of about 1 centimeter are made, and a larger, about a 3 centimeter incision is made. So the surgery is done with scopes. So you can imagine the morbidity, pain, recovery is much shorter than it used to be. And in our setting, Dr. Mitchell does almost all of his cases, including some pneumonectomies, with VATS surgery. So how would you expect patients to do? This is a collection of patients around the world, including Dr. Koh's group, as well as 2 studies from National Jewish. And really, the bottom line is that if you send someone to surgery, what do you get? What can you tell them that's going to be good for them? Well, the main thing is they're going to convert their cultures to negative. If you look at this column here, these are people who are going to surgery in general because they can't convert their cultures to negative. But 88%, 94%, 100%, 100%, 91, very high rate of converting cultures to negative. So that's one thing you can say very confidently to patients, that you're going to convert your culture most likely. That doesn't always equate with cure, but it's the first step toward cure. Now, I mentioned that two of these were done at National Jewish. Dr. Mitchell, his first publication, 2008, followed though by, I think, a more relevant publication by you that was in 2011. Why is it more relevant? Almost all of these others were open procedures, big thoracotomy scars, a lot of pain afterwards. But the one by you, they were all VATS procedures. So what did we see? Complication rate was 7%, mortality 0%, post-op mortality 0%, conversion rate 84%, and even had some data on relapse, which was 16%. Some of that is probably reinfection. So the cure rate in these patients was very high, at least in a couple of years of follow-up. So with that surgery, we felt that we were able to really support their overall treatment with something that we're calling an adjunct. They were in the hospital about 3.3 days. So this is something to consider, but I really think that it should be done with video-assisted surgery. This is one of my patients, 56-year-old Caucasian woman who developed hemoptysis. She's a very active, healthy person and just coughed up blood. And it turned out she had both MAC and abscesses. We ended up treating both, and she continued to have abscesses. We got rid of the MAC, but we couldn't get rid of the abscesses. She was so healthy, she had such focal disease, so she underwent video-assisted thoracoscopic surgery and was cured of her abscesses. There are two studies, one from us and one from Dr. Koh's group, showing that in the setting of Mycobacterium abscessus, which is so hard to cure, that if you have surgery, you're more likely to have culture conversion. And at Samsung Medical Center in Seoul, it was 58% cure with medical treatment alone, 88% with medical plus surgical. At National Jewish, it was 39% with medical versus 65%. Both of these were statistically significant improvements. Yes, these are highly selected patients. So you shouldn't just show up and say, please take my lung out. It doesn't work that way. But in selected patients, even with almost incurable infections, there's a greater chance that we will cure them. Now, this is important because of volume. Dr. Mitchell published these data showing that from 1983 to 2006, in their first publication, that the mortality was declining. He felt that this was a combination of increased volume. He was getting better as a surgeon, but also he was working with us, and we were making sure the patients were well treated. They were nutritionally sound. All their comorbidities were treated. So, I mean, I would say that all of that is true, but Dr. Mitchell's a good surgeon. So let me get back then to where we started. So these adjuncts, are they adjuncts? Well, I think airway clearance is not an adjunct. I think it's an essential component to the treatment of patients with pulmonary NTM who have bronchiectasis. Treatment of comorbidities, I do not believe is an adjunct. I think it's essential to have good outcomes, to be able to treat the bronchiectasis, the cystic fibrosis. Nutritional support, I don't think it's an adjunct. I think it's an essential component of the management of our patients. Okay, immunotherapy, maybe that's an adjunct. But, you know, maybe it's not going to be. Maybe in a couple of years, I'll be back telling you, no, we've got randomized trials, and this is something we should be doing for our patients. And then finally, surgical. Sometimes it's an adjunct, but sometimes I don't believe it's an adjunct. I believe it is an essential component to cure that individual. Now, that's pretty much all I have to say, except that Dr. Southfinger and I didn't do this on purpose. The maroon bells, they must be really good, so come to Colorado and check them out. Thank you.